All right, hello everybody. I think we're going to get started. Thank you for coming. And today's topic is thoracic ultrasonography, which often sounds very simple. So hopefully there'll still be some important takeaways for everybody here today, and we'll come out with clarification of some misconceptions. And hopefully it'll be a little bit quicker than usual as well. So please feel extra free to interrupt at any time with any questions. And please let me know if you're having trouble hearing me, because I'm trying these headphones for the first time. So this is what we're up to in our curriculum plan and progress. This is the 6th lecture. This is the first one that's moving away from cardiac echo and moving into thoracic ultrasound. And eventually we'll do lower extremity DVT assessment and then echo for the assessment of shock as well. And our goal for today is to understand practical uses of thoracic ultrasonography and avoid common pitfalls. And the hidden agenda will be to share with you my impression of the importance of using lung ultrasound protocols. And is everyone seeing the right screen? Can I just clarify, because I also switched computers?
Yes.
Okay, thank you. All right, so these are our objectives, ABZs of lung findings and artifacts, and then we're going to focus on using lung ultrasound for pneumothorax effusion and pneumonia. We'll go through a few cases and protocols, but because lung ultrasound is so easy, I wanted to start with a brief quiz. So if you don't mind, I had trouble with pull everywhere, so I'm doing this a little bit backwards, but please text. I'm going to show you an image in just a second, but please, if you could open up your phones and text JRubin262 to 37607. And I just activated the poll, so it should work. And the question for you all is this: does this patient have a tappable or a drainable pleural effusion, either a thora or a chest tube, whatever it is, but does this patient have a tappable or drainable pleural effusion? Yes, no, or don't know, can't tell. All right, so I will show you the responses here. So you guys can see this. So we've got 60% saying yes, it's a tappable, drainable pleural effusion, 40% who don't know or can't tell. Question is, does this patient have a pneumothorax? And the question is now live. Does this patient have a pneumothorax? Almost certainly not. Don't know, can't tell. The answer here is almost certainly has 40%, almost certainly not has 20%, and don't know, can't tell is also 40%. And one last question for everybody. What type of consolidation is this? Almost certainly a pneumonia, almost certainly atelectasis, don't know, can't tell. Poll is, here's our answer. So we have 44% saying almost certainly a pneumonia and 56% don't know, can't tell. So I'm glad we did this, because I will tell you that the minority answer in every single question was correct. So if you were in the minority in every single question, you are correct. And if you were in the majority, you are not. So stay tuned, and I will share with you some common misconceptions and pitfalls in thoracic ultrasonography. Are we all seeing the objectives again?
Yes.
All right, so here we go. Lung ultrasound for pneumothorax. So the first thing to know about pulmonary or thoracic ultrasound is that, unlike cardiac echo, lung ultrasound actually, where in a cardiac echo, you actually sort of see the actual structures. Lung ultrasound is sort of harnessing normal artifacts and identifying what's an artifact. I mean, everything you see basically is artifact, and identifying artifacts that track with normal conditions, artifacts that track with disease. So it always reminds me, not that I'm some well-read philosopher, but it always reminds me of Plato's allegory of the cave, where you're just trying to make meaning out of, shadows and whispers. So it's a little bit more of an art that was sort of grandfathered by this Dr. Lichtenstein in France. But the first thing is, and a lot of the artifacts that you see in both lung disease and health are actually all basically reverberation artifacts. So that's the main artifact I'm going to talk to you about today. So what you're seeing here are A lines. And so this here is subcutaneous tissue. And right here, this thick, this is a patient who has a cardiac probe. You could tell because it has this sort of a wedge shape. It's not a vascular probe. This thick line here is the pleural line. It's the parietal pleura and the visceral pleura sort of working along, moving alongside each other. And then you might notice that this line is almost like a reverberation of this line here. It's a little bit thinner, it's a little bit less dense, a little bit less crisp. And then if you look down here at some windows, you can maybe buy that at some times you're almost seeing a glimmer of another one of these, another sort of almost like a repeat image of this A line here and then here at common intervals, decreasing in density. And what's happening here is what's called a reverberation artifact. So in a normal situation, you have the probe shoots out an ultrasound, it hits the pleural surface, and the wave comes back to the probe. And the probe knows, based on how much time it took for the ultrasound waves to go and hit the pleural line and come back, the probe knows that this is exactly how far away this pleural line is. But when you have something that is so highly reflective, like this pleural line, sometimes a little snafu occurs where when this wave comes back to the probe, instead of getting absorbed by the probe, read and processed and turned into this line, it actually just gets bounced right off the probe without the probe even realizing it, goes back to the same pleural surface, and then comes back to the probe, and this time gets processed by the probe as a line. And while we know that this is the same pleural line that the ultrasound just bounced off of, the probe does not know that. To the probe, it's as if the line went twice as far and took twice as long to come back. And so it places another line almost equidistantly, as the A line is to the face of the probe, equidistantly places another line that's a little bit less sharp because a lot of the initial waves got absorbed. And then that process can repeat. And so some of these returning waves get absorbed, processed. You see this line over here. Then some actually still bounce off before they're read by the probe. They go down again to the same pleural surface and bounce back. But as far as the probe thinks, it went all the way down here this far. And so it places another line. And that is a reverberation artifact. And these are A lines. And this is a normal finding in lung ultrasound. Any questions about A lines? Okay. Now, these are normal. Then you have B lines. Now, B lines here are these white waves that are sort of emanating from the pleural surface. They move with the pleura. The pleura moves, lung sliding. We're going to get to that soon. Sometimes there's so many that they coalesce into like one big beam, almost like here. But these are B lines. These are B lines. And one fun fact to know about B lines is that they do rule out a pneumothorax if you find them, because they're sort of moving along with a pleural line and with lung sliding. And so lung sliding is the same idea, that lung sliding sort of rules out a pneumothorax at that spot. So B lines will also rule out a pneumothorax. Now, where do B lines come from? So they're also a reverberation artifact. But the fact is that as much as you might hear people talk about, the exact cause of B lines, and it's due to little pockets of fluid that are close to the fissures or the pulmonary lobules, the bottom line is we don't really know. So Daniel Lichtenstein here, who's among other very well-known echocardiographers or thoracic ultrasonographers, they put out their international evidence-based recommendations for point-of-care lung ultrasound. And they defined B lines as discrete laser-like vertical hyperechoic reverberation artifacts that arise from the pleural line. They extend to the bottom of the screen, that's important, and they move synchronously with lung sliding, and they don't really know the anatomic and physical basis of B lines. What we do know is that it's associated with pulmonary edema. So B lines generally are associated with wet lungs. That could be fluid, it could be inflammation, it could be ARDS, it could be a pneumonia, but it's generally not a normal finding if you see 3 or more B lines in a field, and generally correlates with edema. And then finally, you have Z lines, which are also reverberation artifacts that look similar to A lines, right? These are generally thought to be reverberation artifacts from some high reflective tissue within the subcu tissue. And so one feature of this is that because the subcu tissue does not move, Z lines will not slide, unlike B lines. Z lines will sort of stay here. And the Z lines generally don't reach all the way to the bottom of the field. And so this is basically one person's discussion about Z lines. I think the most important thing to know about Z lines is that they are not B lines. So if you're going to be using B lines as a form of identifying pulmonary edema, then make sure that they move, that there's lung sliding, that they reach the bottom of the field, that they're not reflecting something in the subcu tissue. Make sure, in other words, that they are not Z lines. And this concludes the ABZs of lung artifacts and findings. Any thoughts or questions about this so far?
There's a question from Helen, who doesn't have a mic.
Oh, perfect. Thank you. Sorry, I see it now. Thank you. sorry, I don't have a mic. Why does the probe think it takes longer for the return signal in A lines? So thanks, Alan, for the question. So what happens is that, the first probe comes out, the first ultrasound wave comes out, it hits this pleural surface, and it comes back to the probe. And the probe, the piezoelectric crystals inside the probe sort of absorb that ultrasound energy, and they convert it to electrical energy, and then it gets presented to you as a pleural line. But sometimes when the reflection is so fast and sharp, and I'm not a physicist, but when it's so robust, some of these lines, instead of being processed by the probe, for whatever reason, the probe does not process them, and it sort of bounces off those crystals and does one more trip before it gets processed by the probe. And so because of that, the way that when the probe gets this second signal, the probe doesn't know that it bounced off of something that was here. The way the probe knows that something is here is based on how much time it takes an ultrasound wave to come back. So it says, okay, I know how fast the ultrasound waves move in soft tissue, and I know this thing took 2 seconds to come back, which means it took 1 second to reach whatever it is that it hit. And so using the speed and the time, it knows that there's a pleural line here. But if it bounces twice before the probe reads it, the probe just thinks it went twice as far. And then the probe says, oh, there must have been a line here. All right, okay, perfect, okay. All right, so any other thoughts or questions about A lines, B lines? You could have A lines in pneumothorax. You don't necessarily have, generally B lines, like I said, rule out a pneumothorax. Z lines are just not B lines. Let's move on. Pneumothorax. So this is lung sliding. Lung sliding is famous. And this, you can tell we're using a vascular probe because it's a box here. It's not a wedge shape. And the vascular probes tend to have higher definition when you're looking for lung sliding. So here you can probably tell that there's lung sliding right here. And what this means is that everything until here is subcutaneous tissue. Can anyone tell me what these black circles are?
No.
Ribs. Thanks, Adil. So yeah, these are ribs. So they cause a lot of shadowing. Bone and air are sort of the enemies of the ultrasound. But whereas bone sort of creates the shadowing where everything is gone, air creates artifacts, which we have learned to harness, right? But so these are ribs. This is subcutaneous tissue. And generally when people are moving and breathing, their subcutaneous tissue doesn't move that much. But your lungs, as they inflate, inhale, and exhale, the lung pleural surface slides relative to this subcutaneous tissue, and you could see this sliding. Sometimes it's easy to see, sometimes it's not, but you might notice that the lung tissue is sliding relative to the pleura. This means that there's no pneumothorax here. This means that you're seeing an actual lung at this spot that's moving and opening and closing, or inhaling and exhaling. Visceral pleura moves relative to the parietal pleura or the subcutaneous tissue. That fact, whether or not it's truly visceral and parietal pleura separately is up for discussion. This is a normal finding. Now, absence of lung sliding. So here you could tell this is one of the first pictures I gave to you all. And you could tell that there's some movement here, right? But this is the subcutaneous tissue and the lung tissue sort of moving together. The lung is not sliding relative to the subcutaneous tissue. This is just someone whose chest wall is moving, or maybe they're inhaling or exhaling a little bit, but the lung here is not sliding. Now, very often people think no lung sliding, and they hear 100%, and they try, and some people misremember 100% specificity, which is not the case. Lung sliding is absence of lung sliding is 100% sensitive for pneumothorax. If you have a pneumothorax, you can't have an inflated lung that's opening, that's inhaling and exhaling, that's moving. You can't have that, but it is not specific. It's not even a little bit specific. It's extremely non-specific for pneumothorax. Absence of lung sliding does not mean a pneumothorax. You can think about many other things that would cause the absence of relative sliding of the lung. For example, a patient had a pleurodesis, right? Then you don't want the lung sliding at that spot. If they have blebs or COPD, or they're not moving a lot of air at that location, then the lung isn't moving much and it won't slide. If you have a main stem intubation, then the lung will not slide on the other side. If you have very low tidal volume ventilation, if you have a pneumonia and the lung is just consolidated. And one of the things that I like about ultrasound is that once you understand the principles, you can apply them to unique situations that you might not even be able to think of. So any other cause you could think of for whatever it is for your patient, why their lung might not be moving relative to their subcutaneous tissue might be a cause of absence of lung sliding. So when you see absent lung sliding, you can think of a pneumothorax. You should think of a pneumothorax, especially in the context of whatever it is that made you slap a probe on the patient. But don't forget all these other many causes of lung sliding. Don't stick a needle just because there's absence of lung sliding. We're going to delve into this a bit more, but what if you're not sure? So this is a patient who has a cardiac echo probe, right? And sometimes with the cardiac echo probe, it's actually harder to tell. Some people tell you to look for shimmering of the pleural surface, and that's sort of a sign of lung sliding. And very often you'll be using your cardiac probe because you can use the cardiac probe. And if you're doing this right after you as part of your critical care echo, you don't want to always be switching between probes. So it's very common to use a cardiac probe when you're doing your thoracic ultrasonography. And then you look at this and you say, I'm not sure if there's lung sliding or not. So for troubleshooting, you have two options. The first is to actually just go ahead and switch to a vascular probe because you'll get this much better definition, higher resolution, lower frequency, or higher frequency image, and you'll be able to see lung sliding really nicely, right? And then your other option is the famous M-mode sandy beach sign, right? So here you have this lung and you have this subcutaneous tissue that's not moving, and here you have a lung that is moving. And you might not be sure, is this lung sliding or is this not lung sliding? I can't tell. So you put an M mode on it. And as you know, M mode will record over time everything happening underneath this line. So nothing is happening underneath this half, underneath the sub Q half. So you just get a straight line. This is akin to a waterfront. But the lung that is sliding is constantly moving. And so it creates this sort of sandy-like appearance on the bottom half of the screen. So this is called the sandy beach appearance. And this is using M mode to sort of confirm that there is lung sliding at this location of this M mode. So those are two ways to sort of identify lung sliding if you're not sure if it's there. If you don't have lung sliding, you have what's called the stratosphere sign. And this is basically nothing is moving here at all. So you're just getting straight lines all across the beach. The whole thing is just water. There's no beach. It's all stratosphere. It's all not moving. Any thoughts or questions so far? So some of you are probably still wondering why that first case was not a pneumothorax, and we'll get there. So before we do that, lung point, very famous. Everyone hears about it. It's always on the boards, right? Lung point is the only finding that's really 100% specific for a pneumothorax. And what you have here is some lung that's not sliding and then some lung that is, which means that in this case, there's 100% specificity for there being a pneumothorax at this spot. And what you're seeing in lung sliding is if you can look at this sort of cross-section image of a CT scan and imagine you put your probe right here, right? So right now, if you put your probe here and you did a little M mode or you didn't do M mode, you just slapped the probe on and looked, there would be no lung sliding here because the lung is all the way down here. The probe, once it hits, the probe is coming in from the side, let's say. Once it hits this air, the beams scatter and you get nothing. So there's no evidence of any lung sliding. But then the patient inhales. And some of that lung sort of expands. Some of this lung that's not collapsed sort of expands a little bit. And now it crosses your probe. And so now you're going to see some lung sliding there. And then they exhale and it goes away. And now there's no lung sliding. And so that's what you're seeing. And so seemingly the only cause of this finding would be a pneumothorax like this. None of the other causes that I've described to you would seem to cause this finding of lung point. So everyone gets really excited about talking about lung point. And if you find it, then it's, lungs, like I said, it's 100% specific for pneumothorax. If you find it, then like good for you, congratulations. I have never been so lucky. I think it's extremely uncommon to actually find it. So while we talk about lung point as this like magic finding of pneumothorax, clinically, it's not something, it's not very sensitive. It's not easy to find. It's fun to test. It's fun to see. It's fun to write case reports about. But to me, it's not the most useful thoracic ultrasound finding when we're talking about a pneumothorax. So this is sort of a repeat of that first question. You finished placing a left IJ 10 minutes ago. The patient's now hypotensive, concerning for pneumothorax. Chest x-ray hasn't come. You grab your ultrasound. You don't see a lung point, but you do see absence of lung sliding. So what do you do next? Well, I sort of already said this, so I guess I repeated this question. So you're not going to do a needle decompression. What you will do is you'll do this ultrasound and you get this finding. Does this help? Oh, thank you, Colleen. Not that rear post procedure. Fair. Does this patient have a pneumothorax? So, I mean, I already asked this question. This was the first question, and the majority said that this patient does have a pneumothorax, and that's probably because you're seeing no lung sliding, and you have a strong reason to clinically suspect a pneumothorax, and you see what looks to be a stratosphere sign. But there is something else hiding in this M mode, which actually tells you with absolute certainty that despite there being a stratosphere sign here, this patient does not have a pneumothorax. And this, I believe, is the most important finding for thoracic ultrasound when you're talking about a pneumothorax, because what you did find is lung pulse. And what that is that if you look at this lung very carefully, it's pulsating. Now, when a lung is moving and there's lung sliding, now the pulsating obviously is reverberations, not artifact, but physical reverberations from the heart that's pumping. And it's the parts pumping is reverberating and causing the lung to move, right? The lung to pulsate. Now, if the lung were lung sliding, you wouldn't see this because it sort of just gets absorbed in the motion. But when there's absence of lung sliding, you can see the lung pulse. Now, if there were a pneumothorax and this was all air between this and the lung, you wouldn't see this because it would be the ultrasound beams would get lost in the air, would refract, would scatter, and you wouldn't be able to see a lung pulse. The fact that you're seeing a lung pulse, and that's what this is called, a lung pulse, proves that there's apposition of the lung to the chest wall. Ergo, rules out a pneumothorax. Now, this might be subtle. This might be hard to see. But you can see it. So sorry, I put up some words here. Visible when lung sliding is absent, rules out a pneumothorax. I think this is much more common to find because very often when I'm seeing absence of lung sliding, it's not a pneumothorax, and I want to be confident that it's not a pneumothorax. Now, but like I was saying, you can't always see it. It's sometimes hard to see, but if you slap an M mode on it, look at these vertical lines that we're hiding in plain sight at approximately the same rate as the heart rate, right? What that's happening here is you have a stratosphere sign, but with every heartbeat, there's a little wiggle, there's a little motion, and you're starting to see that. And you can see this on M mode through a stratosphere sign. So this is a great role for M mode. This was visible on that first case that I gave you. So the answer to that first question where I gave you this exact M mode, where you could make out that there's a lung pulse and that ruled out a pneumothorax. And this is extremely helpful at the bedside because very often it's not there. Very often it's there and you don't have to worry about looking for this large bore needle. So that's all I want to say about lung ultrasound for pneumothorax. Does anybody want to ask any questions or chat about this?
Hey, Jonah, it's Brian.
Hi.
Hey, so I think it's nice because, like, you know, if you're in that sort of situation after the fact, and you ultrasound the lung, and oftentimes it's a little confusing what you see. It's nice to like get in the habit of just like you ultrasound the neck vessels before you start the procedure, to just take a quick look at the lung on the same side and look at how the sliding looks, to be able to compare pre and post procedure. If you don't see like fantastic lung sliding pre-procedure and then patient becomes hypotensive afterwards, you have something to compare it to.
I love that so much. Thank you for sharing. Completely agree. That's a great point. Thank you. Any other thoughts or questions? Okay. So that's all I want to say about lung ultrasound for pneumothorax. Now I'm going to get on to effusion. And pleural effusions, when you're assessing them, I think we do this a lot for our thoras, so I'm not going to belabor it, but obviously you want to make the effusions as dependent as possible. So if the patient's sitting up, you can look at their back. If they're in bed, you want to elevate the head of the bed and look at the most dependent portion. My question for the group here is this a simple or complex pleural effusion?
Simple.
Yeah, agree. Very simple, right? It's clean, dark. You've got some atelectatic lung over here that's sort of flapping. Sometimes this is called a jellyfish sign, but this, right, clean, dark, very likely to be a simple effusion. How about this right here?
That's loculated with fibrinous strands there.
Yeah, exactly. So this is complex. This is we're calling IP, considering a chest tube if we feel that this needs to be drained. And then this is extremely complex. This is a malignant pleural effusion, and lots of other discussions we're going to be having there too. So you can already get a sense just when you're looking at a pleural effusion. Sometimes you can get a sense of what you're dealing with. That's not the purpose of today's talk, so I'm not going to get into it. Now, this was question number 2, and I asked if this patient has a pleural effusion, and most said that this patient does have a tappable pleural effusion. Anyone who said no? Well, actually, before I do that, let's move on to this. How about this? Does this patient have a tappable pleural effusion? This patient?
From the words of IP, everything is tappable, but
So what I
it
want to point
depends
out,
on
I'm
if we
not so
should tap it
sure
or
that
not.
was a diaphragm though.
thank you,
Go
Colleen.
back,
So
go
every
back.
single one of these cases are ascites, not pleural effusions. None of these are pleural effusions, right? And this, I think, is the most common misconception and time where people can unwittingly do a paraspinal paracentesis rather than a thoracentesis. And so this is, I think, the most common misconception, the easiest mistake to make. And so I want to help you figure out how you're never going to make this mistake. This is, by the way, the ligament of Treitz. Or the falciform ligament or something like that. Falciform ligament, that's what I meant, of the liver, ascites, subdiaphragmatic ascites. This is your diaphragm. This is your diaphragm. Here, you don't see any diaphragm. And so let me help us not make this mistake. So if there's an effusion, if you are looking for a pleural effusion, you must find the diaphragm. If you do not find the diaphragm, then you don't know what you're seeing. Now, usually the diaphragm is thick or appears thick on ultrasound when it's overlying the liver. And some of that is just, I think, some of the diaphragm sort of mixing with like the liver tissue, and it just sort of looks thicker than it sometimes it might be. So here you have a diaphragm. You can see the costophrenic angle, the diaphragm meeting the chest wall. And here you can see the liver, and here you can see pleural effusion. This is clearly a pleural effusion. It's tappable, it's drainable. Go for it. Sometimes this happens where a patient has ascites and they have both a subdiaphragmatic ascites and they have a pleural effusion. And often I have found in these cases, this makes it even look thicker, but often sometimes I found in these cases that the diaphragm can look very, very thin. And you can actually go up and like pass right through the diaphragm, and sometimes without even appreciating that it's there. But this here, this is on the left side. So this is spleen, liver, subdiaphragmatic ascites, diaphragm, consolidated atelectatic lung, pleural effusion. Okay. So when you're looking in a normal lung, just to get there, and then I'll come back to those other images that were all ascites. When you're looking at a normal lung, what happens is when you're sliding up from the liver, like you might make out some diaphragm here, but then ultimately you slide up. If there's no pleural effusion, you get just what's called this curtain sign. You're like in liver, and suddenly you're curtained and you're in lung. And to me, that's a sign of a normal, no pleural effusion, right? Even on this curtain sign, you actually can make out some of the A waves, A lines, A line, A line, A line. And clear liver becomes clear lung. So when I'm looking for a pleural effusion, I will start deliberately low. Usually in the ICU, I'm starting, in their mid-axillary line or a little bit more posterior if possible. I start deliberately low. I try to find the liver or the spleen, and then I slowly scan upward with the ultrasound probe until I either find the diaphragm and an effusion, or suddenly I'm in the lung and I never even noticed it happen, in which case I know that there's no pleural effusion. In all these cases, you can tell that this is not a pleural effusion, because so for example, first of all, here, look at the liver. You don't have this sort of thick outline that you often have down here. You're starting to see it, but you don't see this here, any thick diaphragm like you're seeing over here that's usually overlying the liver. But the other thing that you're not finding is if you're going to tell me that this is the liver overlying the diaphragm, where is your costophrenic angle? Follow this down. And what you'll find is eventually you're seeing bowel and small intestines. If you can't find a costophrenic angle, then you didn't find the diaphragm. So if you're not sure, you have to keep scrolling. Now, if you would have scrolled up with your probe, you would have found where this diaphragm sort of hit the wall and gone above it, and you might have found that this patient does not have a tappable pleural effusion. Here also, so this patient, you could say, oh, I found theoretically a costophrenic angle, but again, there's no thick diaphragm overlying. You might see this, which is potentially a diaphragm, and you have to just scroll up to make sure. This could be, in theory, like if I didn't see this here and tell you that that was the diaphragm, or maybe that's some collapsed lung that's floating in space. In theory, it could be possible. It's not likely to be the case because you don't have the thick overlying diaphragm, but also you have to scroll up and find the lung and find the diaphragm. And here too, same problem. So you don't have the thick overlying diaphragm, you don't have a costophrenic angle, you have to keep scanning upwards, and sometimes you will be surprised how high the diaphragm can rise. Sometimes you're literally in the axilla when you're finding the diaphragm. It's not uncommon at all. Sorry, Colleen also made a comment. So this is a more serious mistake when performed on the left. There have been cases of blood in ventricle mistaken for pleural effusion. I would also argue you'd better prove it's definitive of pleural effusion if you are below rib 8. Thank you, Colleen. And please feel free at any point. I feel I'm humbled to be talking with you, listening. Please feel free at any point to correct or add in word or in text. But so just to reiterate again, scan all the way up, find the diaphragm, make sure what you're seeing is a pleural effusion. Don't tap ascites. Always find the diaphragm. That's all I have to say about lung ultrasound for effusion. Any other thoughts or questions or addition or tips?
Hey, Jonah.
Yeah.
Brian again. So I don't know if you're going to go on to this, but I think, at least in my experience, what preset you're on kind of matters a lot, or for, the quality of your images when you're looking for, effusion versus pneumothorax and B lines and that sort of thing. Like the lung preset on the machines turn off like harmonic imaging and that sort of thing. So, you can actually find B lines and A lines versus the, when you're looking for the like effusions or consolidations, I just find that the abdominal preset actually usually gives you a higher quality image. I don't know if you found the same thing.
Thank you. That's helpful. Sometimes I think, and especially if you're using your abdominal probe to do, let's say, a fast exam. I haven't generally had issues using the cardiac probe, to be honest. So my practice
no. I'm like I still use the cardiac probe, just the presets for the, like the settings.
I see. Yeah.
Yeah.
I generally just still use the cardiac, and I haven't had issues. I'm usually on cardiac and then I just use it to scan over the lungs, but I've never played with it if people have issues.
Yeah. I like, I would try out the lung preset when you're like, it oftentimes will bring out the B lines.
That's helpful. Thank you.
For you. Yeah.
That's great. Thank you. All right.
I was also just going to say with ultrasound, if you're having trouble with contrast, especially when you're looking at pleural effusions and other structures, there is a button that's basically an auto contrast that maximizes the contrast between isoechoic things and hypo and hyperechoic things. So sometimes that might help you if you feel like you're having a little bit of difficulty seeing differences or having good resolution.
Oh, thank you. I'll find you to find out where that button is. Thank you, Colleen. I guess on that topic also, sometimes I think if you're overgained, you might see artifact that appears to be stuff that might make a simple effusion look not simple. So you might also want to reduce your gain, but it sounds like this magic button that Colleen is mentioning would be even better. So thank you. Okay. And then finally, lung ultrasound for pneumonia, the other key cause that I often use this for, I guess left out of this discussion, is diaphragmatic ultrasound for, I guess, just to put a shout out for, there's studies on using diaphragmatic ultrasound to assess for weakness and extubatability. I haven't really incorporated that into my practice. And as far as I know, the diaphragm isn't going to get stronger by keeping patients intubated longer. So there is prognostic information that you can tell about patients' likelihood for reintubation potentially from using diaphragmatic ultrasound. And potentially maybe it'll inform whether or not you want to extubate to BiPAP or CPAP. But I don't know that this has got, that the data is all there yet for this to become like a regular practice. So that's excluded from this discussion, but that's a shout out to the fact that that exists. Lung ultrasound for pneumonia. So Dr. Lichtenstein also identified these findings where you can have, if you have a translobar pneumonia, you get what's called the tissue-like sign. So this whole lung looks like almost like it's a liver, like hepatization of the lung. And if you have a non-translobar pneumonia, like it's just in one spot, sometimes like partial lobe, then this is all normal lung. And then you get this sort of shred-like sign where it looks like someone's eaten into the lung. I generally don't clinically distinguish between translobar and non-translobar pneumonia. So I don't find this incredibly important other than to recognize that these are both different things that could look like a pneumonia. Often I personally don't end up using ultrasound really to diagnose pneumonia very much, but what happens is sometimes you're looking on an ultrasound for another reason and you get a look at the lung and you might wonder like, hey, this looks strange. So it might be helpful to know that this is consistent with, with just a pneumonia finding. It's not that someone actually took a bite out of this patient's lungs. And this too. Now this here is does anyone know what this is called? This was the third question I offered. What are these white things coming in and out?
Air bronchograms.
Yeah, thanks. And these are dynamic air bronchograms in that they're coming in with each breath. And when you have, so this is a consolidated appearing lung, this would be a translobar pneumonia, right? It's all tissue-like, but in addition to having tissue-like sign and you have a collapsed lung, you have air bronchograms, which suggests that this lung is actually not completely collapsed. If it were completely collapsed and atelectatic, then there wouldn't be air going through the bronchioles, right? So usually when there's consolidated lung around the bronchi, then the air is going through the bronchi with each, or the bronchioles with each breath, but it's not getting it all the way to the lung because the lung is consolidated. So this dynamic air bronchogram has actually been called likely specific for pneumonia versus atelectasis. It's 94% specific and has a 97% positive predictive value. So this is just a helpful finding to know if you see a pleural effusion and dynamic air bronchograms. You know, if you see a pleural effusion and collapsed lung, you might think that's just atelectatic lung from this large pleural effusion. If you see air bronchograms too, and you're hemming and hawing about whether or not this patient has pneumonia, this patient probably does. If you don't have dynamic air bronchograms, that does not rule out a pneumonia. It's 61% sensitive, 43% negative predictive value. So you can definitely have a pneumonia without air bronchograms, but if you see dynamic air bronchograms, it's almost certainly a pneumonia. So that was the correct answer to the third question that I asked. So I'm going to finish up with just a couple of very, very brief one-off, one-slide cases and protocols. The first, though, is just to note that there are many, many protocols about using thoracic ultrasonography, which zones you should go to. This is just one paper that sort of compared many different protocols using COVID. And I have to say that if you want to do this correctly, if you really want to do this correctly, you must be doing the 72 zone protocol. I'm just kidding, right? That's nuts. No one's going to be doing a 72 zone protocol. So there are protocols out there. Some are more useful than others, but by far the most famous protocol is the blue protocol, also featured by Dr. Lichtenstein. And what I find at least helpful about this one is that there's only 3 spots on each side. There's 2 anterior, and then this P-lapse point, I can never remember what it stands for, but that's basically where you would go looking for your pleural effusions. And sometimes you don't even need to look there if you're using the blue protocol. But instead of doing the blue protocol, I want to first just go through some cases based on what we've learned so far. So interactive time, get ready to unmute. This is a patient who comes in with acute respiratory distress. What are you seeing in the left lung here? I'm going to call on people if we don't call on some fellows. Elnardo, what are these?
So I see B lines.
Yeah,
throughout.
That's it. Yeah,
Yep.
It's lung. We can't get more complicated than that. And then how about here?
Yep.
Also B lines. So what does this patient have?
Also B lines. So this would be probably fluid.
Yeah, or like pulmonary edema, maybe ARDS,
Yeah,
maybe fluid, whatever it is.
Mhm.
But you've diagnosed, so to speak, pulmonary edema. All right, great. Can I give this case here? This is a patient with acute respiratory distress. And I will tell you that this patient has no lung sliding. Brian, can I give this to you? Acute respiratory distress, B lines with no lung sliding, maybe a little tricky.
Yeah, I'm not sure what that would be.
Oh, okay. So this one's tricky. We didn't say it explicitly, but if there are B lines and B lines all exclude a pneumothorax, so this can't be pneumothorax. So if there's B lines, and B lines can be present in a pneumonia or an early pneumonia. So if there's no lung sliding and B lines, this is probably at least would be consistent with a pneumonia. So the lung's not moving so much because it's all consolidated, but you're getting B lines. So pneumonia. Sorry, trick question. Tricky. That's probably the trickiest question. Similarly, if you have B lines on one side and over here you have nothing, normal A lines on the left side, that would also maybe be consistent with a pneumonia or whatever cause you might have for asymmetric pulmonary edema. Okay. Helen, can I give you this case? You have a patient, and case number 4 in both lungs. This patient has this finding, which are we may have lost Helen, so anyone else can sort of pipe up.
She doesn't have a mic. She said.
Oh, that's right.
A-lines,
Sorry.
and
Oh,
normal.
sorry. Thanks. Forgot about that. And what do you have here? Sorry, I put you on live chat. So this patient with acute respiratory distress, this is the right fem. Sorry for not specifying at the top. I brought in, we didn't do vascular yet, but yep. So PE, right? Acute respiratory distress, normal lungs, and you have a DVT. This patient probably has a PE, not diagnostic. Okay, any other fellows on? Louisa, are you around? What do you do if you have this patient with anterior lungs have this finding and no lower extremity DVT, and you have this?
That looks like a pneumonia.
Yeah, dynamic air bronchograms. The anterior lungs are okay, but this is the lower mid-axillary level. That would be like that PLAPS or that dependent area. So exactly, this would be consistent with a pneumonia. It's not really, again, these aren't straight up diagnoses, but these are sort of guiding your acute respiratory distress evals. Marva, can I put you on the spot? This is a patient, has this in both anterior lungs and this in lower mid-axillary level bilaterally, and is coming in with acute respiratory distress. This is also maybe a little tricky.
All right, so the left image, there are A lines, and I do see lung sliding, so there's a pneumothorax there. And the image on the right, I think that's the liver. I see the diaphragm, and I see the current inside, so I don't think there's a pleural effusion. So I'm not sure what the reason for their distress is. Maybe pneumonia?
Well, it's something that basically any respiratory distress that can have normal lungs, and this patient has no lower extremity DVT, so that leaves like things like asthma or COPD maybe, which I didn't bring up at all in this conversation. But just to say, this is respiratory distress with basically normal lungs, as you correctly identified. And then I think this is the last case, and I won't insult anyone by making them identify lung point. This is lung point. It's on every single pulmonary and critical care board exam. So this patient also has a pneumothorax. Now, this is the blue protocol, and it's got all these complicated lines, a B profile, A profile, A prime, B prime, ABC profile. But actually, I thought I updated this slide, but all 7 cases that we just went through are this algorithm. There's no reason, if you understand all the things that you're seeing, there's no reason to memorize this algorithm. So for example, you have lung sliding and bilateral B lines. We correctly identified that this was pulmonary edema. If you have bilateral lung sliding and you have A lines, but a DVT, we've correctly identified that the patient probably has a PE. If there was no DVT, then either you saw a consolidation with dynamic air bronchograms and you knew it was pneumonia, or you saw nothing. So you had normal A lines, normal lung sliding, COPD or asthma. Or if you saw that consolidation, or you saw B lines on one side and not the other, maybe a pneumonia. If you have no lung sliding and B lines, that tricky question, also could be pneumonia. If you have A lines on one side but not on the other, and you have a lung point, it's a pneumothorax. So going through the blue protocol, I think is helpful for like research purposes to sort of show they wanted to see that there's a tool that could identify, diagnosis with 90% accuracy. That's really nice. But my point is that I don't think protocols clinically are super helpful. This is something we'll talk about when we have our shock lecture too, because once you understand what it is that you're seeing, you can very quickly do this all simultaneously. You're not going to be following an algorithmic approach to your lung sliding and doing, some ultrasounds and then referring back to this blue protocol. So blue protocol, very famous, very helpful. It's definitely put the importance of thoracic ultrasonography on the map. But I don't think that anyone needs to memorize this blue protocol. So I'll summarize our pearls, and then I'll leave a few minutes open for questions. For pneumothorax, use your MO to identify the absence of lung sliding, but also lung pulse. Don't forget about lung pulse. There's many etiologies for absent lung sliding. They're not all specific for a pneumothorax, and it's much easier, in my view, to rule out a pneumothorax using lung pulse than to rule it in by finding lung point. For effusions, make sure you find the diaphragm. Don't tap ascites through the ribs. Complex effusions will likely need an indwelling tube. Not sure why I thought that was relevant for today. And then for pneumonia, you can identify consolidations, and knowing that dynamic air bronchograms are very specific for pneumonia over atelectasis may at times be helpful. And protocols, I think, are great for research, but perhaps less helpful clinically when you understand what you're seeing in your patient's context. So thank you all for participating. Hopefully you learned something, and I'm available for any thoughts or questions or anything else anyone wants to add.
I have a quick question, Jonah. So in terms of, I always find it difficult to kind of differentiate at static and dynamic. So static, pretty much you'll continue to see the air bronchograms throughout the breathing cycle?
Yeah, yeah, exactly. They'll just be like in place. You'll just see these white lines that are bronchograms. So the dynamic is where they sort of come in with each breath.
Okay.
Exactly.
Awesome. Thank you.
Yeah, for sure. Any other thoughts or questions? All right, well, everyone has to remain here until 1 p.m. Just kidding. Thank
Thanks,
you all,
Jonah.
and I'll see you. Thanks for coming and thanks for participating. Bye-bye.